So first off, could you just give me a bit of your own background in oncology?
Sure. So I am from Michigan, then went to college in Atlanta, and then went back to Michigan for medical school, and then did my training primarily at the University of Pennsylvania in Philadelphia, my internal medicine and then hematology oncology fellowship. And then I've been here at MD Anderson ever since I started my first faculty position back in 2012. So it's been about 8 years now.
Great. So now can you explain the recent Venetoclax approval and what research led to the approval?
Well, the recent approval is a full FDA approval for the combination of Venetoclax with either azacitidine or decitabine, the kind of standard hypomethylating agents for newly diagnosed older patients with acute myeloid leukemia. So that was a really kind of important kind of approval and day for us. What led us there is a much longer story. So it started as, Venetoclax as a single agent in relapsed refractory leukemia patients, where we saw, hints of impressive activity, but it wasn't really until we put it in combination and then moved it to the newly diagnosed setting where we saw such really kind of dramatic responses as well as improved survival in our patients with AML who are older and kind of inappropriate for our intensive chemotherapy regimens. Which is, the majority of our AML patients are, the age of 68 or 70 or higher, and that standard intense chemotherapy isn't a great option. And so this is kind of the first kind of approval in a kind of in a widespread, AML population that is, that's really changing the paradigm for our AML patients.
So why is this approval so important?
It's important because for the past, 30, 40 years, we've been using the same treatments for that older chemotherapy ineligible population, which would be, azacitidine or decitabine or low-dose cytarabine. And those are, very appropriate treatments. But the odds of obtaining a remission were the minority. And the median survival in patients treated with those classes of agents was under a year. So the fact that this combination more than doubles the expected response rate, meaning that people are going into complete remissions. Their counts are improving. They're not needing transfusions. They're not coming back and forth for multiple visits for, count checks and staying at the hospital for transfusions all the time. I mean, it's a major kind of improvement in patient expectations. And then, of course, the gold standard and, what we always are hoping for is, that we're actually improving the overall survival of our patients, which was confirmed also. So that's why this study is so important.
So what would you say is most important for practicing oncologists to understand about this approval?
I think the most important thing is that we really do have, what can be considered a new standard of care for our older patients, and that, just proceeding with azacitidine or decitabine, which is, the two that are most often used here in the United States, may not be, offering patients their best opportunity to, respond and do well. And so this really is something that I think should be, at the top of the list of considerations for any provider seeing newly diagnosed leukemia patients now.
So are there any sort of planned next steps or planned studies within this indication moving forward?
Right. So just because we are doing better than we were before doesn't mean that, that the story ends here. And certainly not everyone responds. And, people that do respond, unfortunately, the majority will ultimately relapse at some point down the road. And so what we're trying to do now is figure out how to make this combination even better, whether it's trying to identify who, based on, the genetics of their leukemia, who really shouldn't be treated with this regimen if that exists, or if you have a specific, genetic profile? Should we add a certain agent to this combination to make responses happen even better? How are we following responses over time? Are there some patients that we can actually stop therapy in the future? So just trying to kind of better understand kind of the nuances of this therapy in the long term, as well as how to make this even more effective for our patients, are our current research goals.
So looking at the field of AML in general, what sort of upcoming research for this patient population do you think is most noteworthy?
There are still certain leukemia patients, based on their genetics really, that are really challenging to there are some patients with certain genetic mutations that don't do well, no matter what. And those in general are patients with really kind of complex genomic structure, meaning like complex cytogenetics and P53 mutations, and things that, just make even all of our approved therapies are suboptimal for that group. So that's where I think we need to be focusing a lot of our current attention. And there are several new agents in various kind of stages of clinical trial development right now, which may be effective in that population. There are P53 potentially modulating agents. There are monoclonal antibodies or immunotherapies for certain kind of programs that seem to be selectively effective or at least impressively effective in P53 mutant patients. And so that's where I think we need to be focusing a lot of our attention.
So where do you see the field of AML being in 5 years?
I would, in 5 years, I think we will no longer be talking about AML treatment in a binary fashion. So right now we talk about treatment in terms of patients who are young and fit for intensive chemotherapy, and patients who are kind of older or for whatever reason, medically or comorbidity wise, unfit for intensive chemotherapy. So we have like 2 different paths of treatment. And I think now that we have more therapies that are kind of agnostic to that, we have targeted therapies that work well regardless of whether you're a young fit or an older unfit patient. I think we're going to start to see kind of treatment plans across the board that are maybe of intermediate intensity and that are effective for all based on a more individualized genomic approach to leukemia.
So looking at COVID-19, how has COVID-19 changed the way that patients with AML are treated?
I don't know that COVID-19 has changed treatment too much well, let me take that back. I think it depends on where you are. So, and the time that you were diagnosed. So, unfortunately right now, the country is ramping back up and numbers are getting high again. And so, I would imagine there are patients who are diagnosed with leukemia that don't feel comfortable traveling. And so those patients may opt to receive treatment kind of at home in a more community-based approach, whereas previously they would be kind of referred to a tertiary kind of city center in an academic center. So there's some of that going on. In terms of the actual treatments received, though, I think those are not significantly modified by the COVID-19 pandemic.
So that's all I had for you. Is there anything that I didn't ask that you think is worth mentioning in this space?
The only thing I would mention, we didn't touch on kind of side effects or tolerability of these venetoclax combinations, and I would just make a point to remind everyone that that responses with these regimens happen really quickly. People do well and go into a leukemia-free state often within a cycle or so, and so kind of doing a bone marrow evaluation at the end of the first cycle to see if your patient is already in a leukemia-free state, and if they are, and the counts are still low, it's real important to wait a week or 2 for counts to recover before you give the next cycle. So just a little bit of kind of nuances in terms of how to best give the combination due to how effective it actually is in some situations is an important one. And there's a lot of guidance out there in terms of how to dose it correctly. But that would just be the only other comment I would make, is if you're using this combination for the first time or two, just to double check some of those recommendations to make sure you're kind of dose modifying in the right way.
Absolutely. Well, thank you so much for taking the time to speak with me. I really do appreciate it.
Absolutely. Thank you so much. We appreciate it as well.